Hi, Priyanka. Hi, everyone. Welcome to the class. Hi, Amrit. Hi, Gifty. Hi, Mubaraka. Hi, Gabby, Tuba, Priyanka. Hi, I'm good. Everything is good, Priyanka. Thank you. Hi, Asma. Hi, Revati. Hello, Karishma, Neha. Hi, Rhythm. Hi, Manshi. Hi, Bhanu, Niharika. I'm good, Mubaraka. I hope you're doing good too. Hi, Leela, Adina, Sonali. Hi, Sonali. Yes, it does feel like a long time. I think we met last on Friday, last week, Friday. So, yeah, almost a week now. Hi, Kanan. Hi, Suyesh. Hi, Nidhi. Hi, Dev. Adina, I would recommend reading the problem solving in Prosto book. That's how I managed it as well when I was preparing it. It's a very small 80-page book and it's not part of the plan, but I recommend it to the students who find it really hard to understand Prosto. So you can message me and I'll share the book with you. It's a very short read, 80-page book. You can read it off in about 2 to 3 hours, but it'll set up your base. So problem solving in Prosto. Hi, Jasmine. Hi, Charu. Yeah, okay. So whoever's having problem with Prosto, like before thousands, if the thousands explanation are also like a bit high level for you, then start with problem solving in Prosto. Okay? I'll share the book also with you. I guess it's on the drive. I'll check it also after the class. Mubaraka, just drop me a message to check it on the drive. If it's not there, I'll upload it on the drive itself. Ready. So I'm gonna upload the problem solving Prosto book on the drive and then you can read that. It's a very short read. It is there, right, Tejasvi? It is on the drive, Gabby, right? So yeah, so it's on the drive already. So you can read that book, whoever is finding Prosto hard to understand, and especially the basics if you're finding hard to memorize. The name is Problem Solving in Prosthodontics. That's it. Let me share my screen. So we'll be doing this session today in two parts. Today, half of it, and then the next half we'll be doing in the next week public session. So I'm covering the new chapter from the eTG, which is the oral and dental health in people with cognitive disability. Now, with ADC, the vulnerable populations and people who require special needs, special referrals, special management, and accommodation for their conditions, those are high priority and high yield concepts in the examination as the new and new questions are coming up. So this new ETG chapters will become a very strong base for everyone to also master the newer questions that could be expected. Now, the cognitive disability is really not a very new topic. In the last two examinations, starting from September 24 and March 25, and even in September 25, so I would say in the last three examinations, this topic has been taking a front seat. Kids with autism, kids with any mental disability, whether developmental or acquired, and then those who are on wheelchair, physical disability, along with the cognitive disability. So these cognitive disabilities can be involving other medical conditions, certain physical conditions, certain challenges orally. So it becomes really relevant in terms of general dentistry management as well, because the specialist needs dentists are also very less in number in Australia. So the referral is also not very straightforward. I mean, yes, it is on paper is very easy to say that refer to special needs uh, dentist, but the number of those specialists is really low. That is why, as general dentist, you must also be fully aware and educated and informed about the management of such population and such group, right? So we are going to do all about these disabilities, what they are, and what are the challenges, what are the risk factors that you would face, what they face. The risk factors can come from their personal conditions. The risk factors can also come from the fact of their service providers. And there are risk factors which can come from the dentist also, right? From the caregivers also, right? So you as well, for you as a professional, also because you would also pose some challenges for them. So what are the risk factors? We are going to talk about the risk factors. Then we should know that what are their challenges orally. There is the primary challenge of the oral hygiene maintenance. That is why we are going to learn about that, how to manage their oral hygiene, how to inform their caregivers, how to involve the entire team, the caregivers, the family members, and behavior specialists. Everybody on the team should be aware of how to manage the oral hygiene practices in such patients. And then what are the strategies that you would apply? What is your role as a general dentist? Because the questions will be surrounding those questions in professionalism and health promotion. Even in treatment planning and evaluation cluster, the questions will come when the day of the appointment, how to book the appointment, what should be providences that you would provide them so that their visit to you is comfortable and you can provide maximum benefit in those visits. And sometimes an extra visit or a longer visit may also be needed, so we are going to be talking about those as well. Then when they make the appointment, then how would you diagnose? Because diagnosis is a challenge in such patients because of cognitive disabilities. They may not be able to express, and especially the pain is difficult to estimate in such patients because they don't even have much understanding, and their expression of pain is different from the general population. So we'll talk about the pain assessment in them, and then how will you plan their treatment? Because once you have assessed their problems, assessed their oral hygiene problems, then how would you plan their treatment? So what are the aids and tools that you can use to provide them the proper treatment, and how you would incorporate them, their caregivers, in it. So today we will be talking about those, and the next week class we will talk about who is going to give consent about them. So how the decision making is coming in such patients, if they're children or if they're adults. Then their caries management. So if they have caries, how would you manage their caries? They are also prone to periodontal disease. We'll talk about periodontal disease in the next class. Then dental malocclusion also is seen because they have skeletal discrepancies. These patients sometimes have oromotor dysfunction as well, which can also contribute to the malocclusion. So we are going to talk about these conditions like caries, periodontal disease, malocclusions, and anxiety, dental anxiety. These patients may have moderate to severe dental anxiety. So how will you manage anxiety for them? How would you use sedation for them? So those clinical aspects we'll discuss in the next part. But in the first part, we are talking about this population group and what are the risk factors and the treatment planning, the pain assessment. So diagnosis, treatment planning, and the risk factors, the information gathering, so predominantly that. And then the complete treatment and evaluation cluster we'll be focusing in the next class, where you will focus on individual disease in such patients like caries, like periodontal disease, or your malocclusions, and then how to manage anxiety and sedation. Right? So everybody understood the flow of the lecture, what we are covering today in the first half, and the next week, the second part of the session. So when you have a clear overview and of the entire lecture, how we are going to progress, it will help you prepare for all the four clusters in a seamless manner. And I want you to flow from one part to the other. And this can be an entire SBQ. What I'm planning is, once I cover this two-part series, I may bring a very short mock on this chapter alone, because this is a very high yield topic. So probably not a lot, but maybe 2 or 3 full size SPQs, so maybe 10 or 15 SPQs. And after completing the next week's 2-part series, we can bring a full 3 SPQ mock, a short mock for everybody, right? So let's do that as well, because then it will be like a full-fledged preparation. And if you remember in the last batch, I think it's on my Facebook page already, or I don't know, if you're enrolled with me, that's already on the app. Anybody remember, I did cover the children with disability class. So this is like a general cognitive disability. This is not just children. But if anyone remembers in the last batch, I don't think the Facebook has it anymore. It should be on my YouTube. I'll ask my team if it's already there. If not, I'll publish it on the YouTube as well. So what I'm going to do is, once we do this 2-part series, and then I'll incorporate, and then I'll give you a homework to watch the children with disability management lectures also. Okay? And you have hot notes also. If you have enrolled with me, you have hot notes on children with disability as well, Gabby, if you remember, right? So you will combine these two lectures together, the eTG cognitive disability chapter, and then the children with disability, where I did the Australian guidelines for management of children with disability. And also in that I covered the service animals also, right? So when I combine all these concepts and topics together, it becomes the wholesome cognitive disability management. It is a huge chunk of professionalism, health promotion, and vulnerable population group topic, right? Huge, huge. Maybe 10 questions in the exam. So when you do it all combined, so I'm going to assign you a homework on our enrolled group also, and for the free candidates also, it would be an assignment from Witspert. Everybody who's not enrolled, is there anyone who's not enrolled but watching this class? I want to know the candidate population here, the group of people who have not joined but joining this class. Just say a hey on the chat so I know that there are also people who are watching it but not enrolled. So if you're not enrolled also, for you, I will announce on the Facebook group the assignment of watching the classes. I'll probably bring all the classes together. Once you complete the assignment, a very short mock on this entire cognitive disability hot topic will be given, right? It would be a free public mock, okay? Probably in the November first week, somewhere that. So you will have about 2 weeks to prepare for this entire topic, okay? So this is kind of like assignment, and you'll prepare it from 3-4 sessions, however they are. I'll publish them, and then combined you weekly plan. No, if you're enrolled with me, this is the part of, you're doing this class today and the next week, and you already have the children with disability is already part of the weekly plan, I see, right? So children with disability class is already part of the plan, but it might be coming a little later. So, but you would do that a little prior as an extra assignment, okay? As an extra assignment, you would do that, because in November first week, I'll give you a short mock on just cognitive disability, so that we take this huge high yield topic, prepare it from 360 degrees, take a test on that, and just be, dusted, done and dusted kind of feeling, right? Yeah, these classes will become part of plan. For enrolled candidates, whatever classes I take, they go to the plan, right? So don't worry about it. But I'm just giving you, before it comes on the plan, it's like an extra assignment, okay? All right, so let's start preparing the oral and dental health in people with cognitive disability. We are going to talk about, first of all, what are the kinds of disability? What are the types of disabilities? Because when you're addressing such patients, these are the impairments which can include developmental. They could be developmental, like intellectual disabilities, autism spectrum disorder. And they could be acquired conditions also, like they could have challenged cognitive functioning because of any brain injury or dementia or stroke related impairment. So dementia and stroke related impairment would be seen in the senior population, and autism spectrum, intellectual disability, developmental, those would be seen in children. They will become your pediatric or children like patients, right? So that is why this ETG chapter covers both pediatric population as well as senior population, adult population. So these are the types of cognitive disabilities. First of all, developmental and acquired. Now, these patients, compared to the general population, they would have higher risk of periodontal disease, dental caries, and also they would have higher risk factors for general oral and dental problems because of their oral hygiene challenges. Their poor oral health can also give them, severe pain, which they may find very hard to express, and it can affect their self-esteem and even restrict the oral function. They may not eat properly, so it can affect their oral function a lot. And sometimes they could be so challenged physically that poor oral hygiene, reduced oral function, and severe pain, it can lead to the local or systemic spread of infections because they may not be able to express the pain. Sometimes in these patients, pain also gets expressed as anger, and there is also risk of aspiration pneumonia, acute airway compromise as well, right? So these are the challenges, and they could have underlying medical conditions as well, which you have to take care of, which is diabetes, cardiovascular diseases, or other chronic diseases. So they have high oral disease risk, and they also have systemic disease risk, aspiration pneumonia, airway obstruction, systemic infection, and the pain can really affect their oral function, difficulty in eating and speaking. So most importantly, you would require in a lot of cases with managing such patients to collaborate with the special needs dentistry specialist. So that specialization is called special needs dentistry. But there is access is very limited. The number of such specialists is also very limited. That is why the predominant management comes under the medical professionals and the general dentist. Does that make sense for everyone? Number one, learning point here. So what are the learning points here so far? What are the types of cognitive disabilities? Developmental and acquired. What are the risk oral diseases that are highly prevalent in them? Periodontal disease, caries, oral hygiene problems, right? Even malocclusions. We'll talk about them next week. The pain can lead to the reduced oral function, difficulty in eating and speaking, and their self-esteem and quality of life gets reduced therefore. The other risk is because of the restricted eating, it could lead to aspiration pneumonia, airway obstruction, and the spread of infection locally as well as systemically. And the challenge is that the special needs dental services or the special need dentistry specialists, they are very limited in number and the access is also limited. That is why as general dental practitioners, along with their medical professionals and their caregivers and family members, you would be handling these patients and you would have the major role in improving their access to dental care, right? That is why this is an extremely important topic for general dentistry ADC exam. You see why it is becoming more and more asked in the examination, why it got a full chapter room in the new eTG. Everybody, this is extremely high yield. I do not want you to miss out on any important information in these chapters and these lectures. Now, what is your role? Right? So your role is to provide their timely assessment. You have to promote preventive practices with them. Aspiration pneumonia is when they're trying to drink something, right? Or trying to eat something. And instead of the food going into the food pipe above, it goes to the respiratory system, to the lungs. So that's like aspirating food, right? Sometimes when the eating is compromised, the patient has a risk of aspirating the food instead of going to the stomach, it goes to the lungs, and that leads to pneumonia, right? Is that clear, Abbas? So because of challenges which are difficulty in eating due to pain, there is a risk of aspiration pneumonia. Is that clear? Yes or no, please, so I can move forward. Now, role of a dentist is to assess, prevent, and review. If you have to memorize it, you have three risks predominantly, which is to provide the assessment timely, minimal annual health assessment should be done, but whenever opportunistically they show up to you for an acute dental problem, for a chief complaint, then also you must assess them overall. Otherwise, such patients should go for an annual dental assessment. Then you should promote their preventive oral care practices, whether it's oral hygiene, whether it's for caries, for periodontal disease. We'll talk about individual disease in the next class, but today we are talking about how to promote preventive oral care practices. Today we'll talk mostly about the oral hygiene practices. Then follow-ups and regular dental reviews. How will you promote them? Right? So these are your three important roles: assessment, preventive, and then review. Okay, sometimes people with the cognitive disability, they report, it has been reported that they have found it challenging to deal with their dentist. So that is why it's a great barrier that dental professionals also sometimes do not know how to incorporate other team members and how to make it a comfortable visit for their cognitive disabled patients. So, with this chapter and with this lecture, we are going to learn about what are their challenges, how you should be prepared for them, and how you should handle them and give them the best experience in your clinic. What are the tools and the aids that you can use by using them, how they can rely on you, and how you can contribute to their, you know, favorable experience in your clinic. Because one bad experience at dentist, it can also generate more dental anxiety, and they can try to resist future dental appointments. So that, and then you will incorporate other team members as well, because it may be challenging for you also to handle it all on yourself. So you will have to discuss with other health professionals. That means who's their caregiver, right? And then speech or behavior therapists and specialist dental services. So these are the three specialists that you will memorize in the examination amongst the options you will be looking for them: speech therapist, behavioral therapist, and specialist dental services. Can anyone write on the chat if it's making complete sense for everyone? Three specialists where you will be referring. If you remember, when I took the sleep apnea class, I gave you the list of specialists. It is important to memorize the specialists also where you refer. Remember? When we did the sleep apnea class, I gave you the list of even sequencing of the specialists. Similarly, here you also should remember the specialist, because in the exam they will give you all the kinds of specialists. Yeah, Amrit, I'm going to repeat it. So speech therapist, specialist, behavioral therapist, and your specialist dental services. So special need dentistry specialist, speech therapist, behavioral therapist, and specialist dental services. These are the referrals or incorporation, kind of like a multidisciplinary approach, Queen. Wonderful, Priyanka, wonderful, Queen. Beautiful, Dave. Everybody memorize these three specialists, which would be part of your team. It would not be like referral to one, but your collaboration with all three or one of the three may be needed. Okay, but remember the names so that you could choose from the list provided. Because then, if the exam gives you, okay, send them to oral medicine specialist, send them to pediatric dentist, or send them to medical professional, and then send them to behavioral specialists, so you know who's your ally in handling such patients. Yes or no? Do we need to know or not? Otherwise, if ADC gives you plethora of the list, right, it gives you medical professional, pediatric, then you're confused, right? Isn't that? Or orthodontist. But speech, behavior, and special dental services, these are your three allies handling such patient. Okay, so that's very important. What is the multidisciplinary team looks like here? Now, what are the challenges that you may have in such patients? Let's talk about the challenges. So there is a challenge in diagnosing their pain. It is really challenging because it is not easy to identify the pain, because they do not have the cognitive capacity to explain even the quantification or quality of the pain, how it is affecting them. So diagnosing their pain is a big challenge. Then their treatment planning is also challenged because they are sensitive to noises, sounds, waiting periods, the crowds and everything. So you have to accommodate all that. And those have been asked as direct questions in the exam. When would you call the patients? When would you keep their appointments? I'm going to tell you all of that in today's class. Then you're assessing their capacity to give consent, whether they have the cognitive capacity to give consents. That's a challenge. Caries they have, erosion is seen in them because of the huge amount of acidic drinks, sugary drinks that they may be taking. Then periodontal disease, some of their Down syndrome like makes them prone genetically for periodontal disease, and poor oral hygiene also makes them prone for periodontal disease. Then dental malocclusion, anxiety, and sedation. So these are the challenges where you would be giving them or dealing with them, and you would face the challenges, right? Now, what are the risk factors? Basically, so what are the risk factors can be divided in their personal factors, which they have because of their own condition, then their caregivers, the challenges or risk coming from who is looking after them, and then the challenges and risk factors coming from their service providers like you, general dentists, or their therapists, hygienists, etc. So the personal challenges or the personal risk factors, number one is because of their oral development. There can be abnormal aberration in tooth formation, like in Down syndrome. They could have missing teeth, hypomineralized teeth, hypocalcified teeth, microdontia. So if it is a developmental cognitive disorder, it is especially like in Down syndrome, then there is genetical predisposition to aberrant tooth formation. They could have craniofacial abnormalities, which could give again severe dental malocclusions. Then delayed eruption of the teeth, ectopic eruption of the teeth, delayed exfoliation of the primary teeth, and oromotor difficulties. So these are their personal risk factors related to the developmental factors. Then their personal factors are also they have reduced muscle tone, right? They could have compromised vision. They also usually have very strong gag reflex. They could have dementia, so problem with memory could lead to they could forget keeping their oral hygiene practices. They could also not find their dentures, they can misplace their dentures. So with dementia patients, have you seen that questions or not in our UF1 and UF2? Patient who displaced their denture, they could have their overdentures on implant supported dentures and they displace their dentures, right? So that is why all these questions are already asked in the examination. So these patients have difficulty with memory. These are the risk factors, and that's why the SBQs are already coming on these risk factors. Then they have a problem that their caregivers, if they try to even give them the oral hygiene, their behavior could be a challenge in receiving that care also. So it is not easy for caregivers to also handle these patients. Their behavior is also a problem. Their anxiety is also a problem because if they have previous traumatic dental experience, they may start behaving in more anxious manner in the next dental visit. So the anxiety management also you should be completely aware of, which we will learn in the next class. But yes, there is a big risk factor in anxiety and behavior modification is needed. Then challenges are tooth formation, aberrant tooth formation, right? So all the challenges are understood so far, the personal ones. Then there's also movement disorders. They could have habitual movements. They could be taking antipsychotic medications. So what is linked with antipsychotic medications? Anyone? I taught you in the last few classes. Antipsychotics, dry mouth, yes, but predominantly one very, very, very important side effect of antipsychotic medication is tardive dyskinesia. Anyone remember tardive dyskinesia? Gingival enlargement is not with antipsychotics. That's with anti-epileptics. Antipsychotics, the moment you think about it, guys, tardive dyskinesia should light up in your brain. Can you remember that? We did it in the bruxism chapter. Tardive dyskinesia, in the bruxism chapter, I taught you that, right? Involuntary movements, when we were talking about bruxism, that it is a separate differential diagnosis, right? Tardive dyskinesia in antipsychotics. Okay, so remember this one. Now, nobody will forget. Yes? And then epilepsy. These patients could have epilepsy. So then think epilepsy and what are the challenges they could have. Now somebody wrote correctly in the previous question. So case selection is very challenging in these patients. You cannot completely say that any is contraindicated, but cobalt chrome is also preferred, right? Because if the condition is highly anxious, then implants can be avoided. Depending upon the severity of the disability, then you make a choice. Okay? Odonto dyskinesia. We did a neuro orodental dysfunction, right? In bruxism, another differential diagnosis. Now, what are the other risk factors is that increase the risk of caries and periodontal disease is they have swallowing disorder, they have dry mouth, gingival enlargement. We will provide you hot notes on these, doctor. Tooth. Sorry, I can't see your first name. So after today's lecture in the next session, after a week, we will provide you the hot notes. So we are providing a separate hot note now, right? ETG chapters. Have you seen it? It has been added on the app. ETG hot notes. A separate folder has been created. Did anybody see that? We added for anxiety, we added for bruxism, we added for trismus. All the new ETG chapter classes that I did for you, they have been added as hot notes as a separate file. They're not in the other subjects. They are on a separate ETG file. So you can read it from there. Okay. So the genetic factors like Down syndrome is also a challenge in periodontal disease, and they consume sometimes highly sugary and acidic drinks, which increases their risk of caries as well as erosion. So the personal challenges are clear. All the developmental factors, the dental abnormalities, the movement abnormalities, tardive dyskinesia, habitual movements, behavioral problems, anxiety, dry mouth, gingival enlargement, sugary drink consumption, because sometimes caregivers use sugary treats as a reward, which is wrong. Which you should also educate the caregivers that for their behavior management, do not give them high sugary treats as a reward. Okay, so that also has to be educated. They have to be educated on that. Now, the caregiver factors are that how their caregiver factors can affect the patient is they may have inadequate education about their risk factors. So they may not know that their patients have these challenges in their mouth, their oral hygiene, swallowing difficulties, gag and bite reflex. So bite reflex is, what is bite reflex? When a child is born, he has a natural bite reflex which slowly wanes away, right? In the first year of life, it disappears. You put anything in the mouth, the child bites. That's the first year reflex. After that, it disappears. But in cognitive disability patients, it may not disappear or it can even reappear after a brain injury or in dementia patients also. Do you did you know that, or would you now remember it? The bite reflex is the first year reflex where you put anything in the mouth and the natural reflex of bite will come in. The child bites, right? Even if you try to put a finger there or any object, they will bite. That's a bite reflex, right? It disappears in the after first year of birth. But in cognitive disability patients, with dementia patients or brain injury, it reappears. So sometimes the caregivers may not know that, and they may try to help the patient eat something and the patient can bite them. So educating the caregivers is also important. They may not know the swallowing difficulties, the bite reflexes, the hyperactive gags also. And see, gags and everything and swallowing disorders again will lead to what problem? We just discussed that. Swallowing problems, gag problems, bite reflexes, these can lead to aspiration pneumonia. Again, life-threatening challenges can become. Bite reflexes when any object is placed near the mouth or in the mouth, the child would bite it, right? Even if it's a baby and there is no tooth, even from the gums, the baby bites, right? If you put anything in the mouth. Remember, anybody seen a baby around you? They're commonly found around you, right? Bite reflex? Yes? Okay, perfect. So, but it fades away after an year, right? It disappears after an year. It's a natural reflex which disappears after an year. But in brain injury and dementia, they reappear, and in adult patients with cognitive disabilities associated with dementia or brain injury, it reappears. So when their caregivers try to feed them, they can bite their fingers. Understood? Everybody. All these caregivers must be educated about. Okay? The swallowing problems, the bite reflexes, the hyperactive gags, all these the patient's caregivers must be educated about. And they also give their patients high sugar and acidic drinks as rewards. So they should be taught about this, or also not, that you should not reward your patients with high sugar, highly acidic drinks or treats. Yes, these also are the risk factors from the caregivers. And they also lack the awareness of the dental services and how to access the dental services. So these are their caregivers' risk factors. Then the services risk factors include what are the challenges that come from you. If you are a private practitioner, you're busy practitioner, you will have less time, for providing solution to such patients. They will require longer appointments. So you have to tell yourself that these patients will not be fast, and if you have a busy practice, you will have to accommodate them. You will have to manage and book their appointments in a way which is not a busy time of your practice, and you give them longer appointments. Be prepared for the longer appointments on them. Okay? Then you would also not know that how to refer them to the specialist need dentistry because the access is limited. So your challenge is also with the lack of training, your lack of training and expertise, and limited access to the specialist needs dentistry. Then your clinic may not have wheelchair access. Then maybe they don't know about the benefit plans. So we'll talk about what are the benefit plans. ADC asks you the names of the plans also. So you must know. So we know the child benefit scheme, but with the disability, there are extra schemes. And sometimes extra expenses may also incur. How to fund them. We'll talk about those as well. So understood your challenges, your lack of time, your lack of access to the specialist need dentistry, your lack of training, your lack of expertise, your clinic not having wheelchair access, your clinic not being aware of all the benefit schemes, right? And if you're a very busy practice, your long waiting times. So all these are the challenges that these patients may have to face, but they're coming from you as a professional service provider. Understood? So far, all the risk factors clear. The personal ones coming from the healthcare givers and coming from the healthcare professionals. All the three challenges understood, the risk factors understood, the patient's personal factors, caregiver factors, and the dental professional factors. Yes, either last appointment or the first or whichever is the least busiest time, you have to give them the longer appointment time. Now, how will you prevent the disease in them? Right? So predominantly you will focus on their oral hygiene. What are their challenges? First, you have to be aware that these patients have challenges to their oral hygiene practices. Why? Because of their motor skills lack. They can't plan. They don't, sometimes they forget, so memory is compromised, and they don't have motor coordination. Child benefit scheme is also added. Yes, Meera. I think it's in the ADA health policies folder. It would be in the ADA health policies hot notes. It would be in the hot notes, not like as a class, but it's a part of the notes. Okay. So these patients have challenges because of the lack of the motor skills, coordination, lack of memory and planning. And they also struggle because of the swallowing difficulties and disabilities, they struggle to manage the fluids and pastes which are used during toothbrushing. So the frothy ones, they cannot stand it. That can lead to even hyperactive gags. So you have to make sure recommending correct toothbrushes and correct toothpaste. Okay. Now, you obviously these oral hygiene, yes. So you would use less foaming ones which do not have detergents, right, Sharia? I'm going to be talking about that. You would recommend them the low foaming toothpastes without the agents like sodium lauryl sulfate. Sodium lauryl sulfate is a foaming agent. So you would recommend them toothpaste without the foaming agent. These are direct exam questions. Is that clear for everyone? Right? So you would advise them low foaming toothpaste. And then, of course, the bite reflex is also a challenge. Gag reflex is also a challenge. So these are the challenges, and that's why you will designate a caregiver to provide them oral hygiene every day. And their caregiver should also be educated upon the correct use of toothbrushing, the correct use of the toothpaste. Right? As a dental professional, what are the strategies that you can provide is you can incorporate the speech therapist, behavioral support therapist, family members, and carers and educate them about the oral hygiene practices. You should document it on the paper, devise a plan, what toothbrush is used, what toothpaste is used, and communicate it to their family members, carers, and support workers. Understood? So it should be a documented plan. What is the toothbrush which is preferred for such patients with cognitive disability? Electric toothbrushes are preferred. Wider handles are preferred. Three-sided toothbrushes. Three-sided toothbrushes. Wider handles and three-sided toothbrushes. Will you remember this one? Electric, wider handle, and three-sided toothbrushes. They help for a wider area coverage. Okay, and you would assign it to their support worker or their carer or the family members, whoever is handling. And if still their caregivers cannot manage them, then you will make the referral to the speech therapist or behavioral support therapist. Suppose a question comes in exam, what kind of, so their caregiver wants to ask you, okay, how can they help in the oral hygiene? Then you will tell them electric, wider handle, three-sided toothbrush, non-foaming, low-foaming toothpaste. That's your advice, right? You will also show them, but there are challenges with swallowing. There are challenges still with the gag. There are challenges still with the patient's bite reflex. Yes or no? These three are still the challenges. Electric toothbrush, wider handle, three-sided toothbrush, low foaming toothpaste. Yes, you have the plan, you have a strategy, but you also have the challenges. You also have the challenges, which is the swallowing difficulty, which is the gag reflex, and which is also a bite reflex. The caregiver can come the next time and they say, oh, I tried to use this toothbrush, I tried to use this toothpaste, still they would not get it done. Yes? Yes or no? These are how the questions flow in ADC exam in the SBQ. These are real-time questions formats that I'm telling you. Then who would you refer to? Then what would you do next? Does the ADC ask you or not? Absolutely yes, Rhythmic. I'm coming to that as well. Then if they are still unable to carry forward, then speech therapist, behavioral therapist, or the specialist need. But predominantly speech or behavioral therapist would educate the patient and their caregiver better. And they will modify these behaviors. They will also work with the patients to reduce those behaviors so that the oral hygiene strategies can be implemented. Understood? So speech therapist and behavioral therapist will work on modifying these challenges. Understood or not now? How it becomes a multidisciplinary management. Yes, wiping methods can also be used, but still toothbrushing is important, especially when the diet is complex. And then along with this, interdental cleaning with brushes, interdental brushes and floss wherever possible should be advised. Okay? Water jets should not be advised in these patients. Can anyone say why? Water jets are not advised in these patients, completely not advised in these patients. Why? Yes, aspiration. Severe risk of aspiration. Wiping can only be an adjunct, especially in children, it's fine, but in adult patients, alone, it will never work. So don't worry about wiping alone. Toothbrushing is required, interdental brushing is required, floss or interdental brushes is required, but water jets is a real risk, especially in people who have swallowing difficulties because of the aspiration risk. Aspiration of water, sweetie. If water gets aspirated into the lungs, it can again lead to aspirational pneumonia, right? What is aspiration? Can anyone define what is aspiration? You can aspire anything. What is aspiration? Can anybody define here? Write down your understanding and definition of aspiration. Sweetie, Vidhi, everybody, what do you understand? Aspiration is accidental taking in of food into the trachea and lungs instead of the esophagus, right? Usually, what usually? Every single day you eat or drink something, it goes into esophagus, right? That's where the food or drinks are supposed to go. Aspiration is because of any challenges in upper respiratory airway or in the throat area or the pharynx area. If the food or drink accidentally goes into the lungs through trachea, it becomes aspiration, which goes into lungs. Understood? Everybody, the definition of aspiration is clear or not? Yes. Aspiration of any liquid or solids. Yeah, even any foreign object. Aspiration could be even of a dental instrument, right? When you're working on them and it goes into their anything, any foreign object, any drug, any liquid, any solid, which is not supposed to go into your respiratory airway. If it gets lodged there, if it goes there, whether in the trachea or in the lungs, it has been aspirated. It is a life-threatening emergency. Understood? Everybody? See, sometimes little bit of liquid can get aspirated, which is fine. But if it is large in quantity, it can get infected and it can lead to pneumonia. And sometimes it can completely choke also. Depends on the severity and the size and the quantity and the amount of the object, Samina, right? Sometimes you can immediately choke. Sometimes it can settle there in the lung and develop into a pneumonia. Understood, Samina, and everyone else as well? Got it? So now so everybody understood the oral hygiene strategy and water jets, why they are not advised. Now the water jet question comes in the exam, everybody would master it. Aspiration question comes in the exam, everybody understood the concept. Aspiration pneumonia question shows up in the history. You're not going, oh, what is this? What is that? Everybody is fully confident in understanding these terminologies. Whenever it presents in the questions and the history, you will confidently face them and you will know what to do and how to manage and who to educate. Nivedita, once I complete these two-part series, I will make the hot notes on this topic also. Every time I take a new topic from eTG, I finish that topic and in a week I will publish that on hot topic. Okay? So notes will be given. Okay? That is a mandate. Goes without saying. Given. Okay? So this is your preventive oral hygiene strategy. Now let's talk about the diet, preventive diet. So you will promote the drinking of water between or in meals in place of sugary and acidic drinks. So reduce the sugary and acidic drinks. Then instead of, so especially the people who have swallowing difficulties, you will not advise them even water because again, the risk of aspiration. Can anyone tell what do you give them? Patients who have swallowing difficulties, what to give them, how you give them fluids. Anyone knows here? You give them thickened fluids. Yes, beautiful. Yes, Sharyar, wonderful. Absolutely correct. You give them thickened liquids, thickened fluids. Okay? There is a less risk of aspiration because of the thickened fluids. So water should be avoided and thickened fluids should be given. Again, exam question. If patient have swallowing difficulties, what would you advise them? Water, thickened fluids. Now, thickened fluids, the thickeners sometimes can be on high on sugar also. Some thickeners may contain sugar. So you have to advise the thickened fluids which are without sugar. Understood? So no sugar, no carb, that strategy, that preventive strategy is crystal clear in everyone's head, right? As a dentist, that's your primary. You start the program with all the caries, CV classes and everything. So I think that goes without saying. No sugar in dentistry, that preventive advice in general population or in cognitive disability. I think that's a no-brainer for everyone, right? This limiting dietary sugars is a no-brainer, applies to every population, right? And every high caries risk population, fluoride varnish also, fluoride toothpaste, yes. So fluoride toothpaste, even up to 5,000 ppm can be advised depending upon their age. Sonali, if it's a swallowing difficulty, water cannot be given. They can aspire it. That's why thickened fluids are given, Sonali. If there is a specially mentioned swallowing difficulty, understood? If there's specifically mentioned swallowing challenges, you would give them thickened fluid, not water. You will use sugar substitutes like xylitol, but also xylitol should not be given too much. Why? Can anyone tell what are the drawbacks of xylitol? Exam question has been asked in the exam. Side effect? Yes, that commonly, but if given too much, it gives you osmotic diarrhea. Osmotic diarrhea. In normal quantity, in flatulence, even in normal quantities, in flatulence, but in higher quantities, it would give osmotic diarrhea. Clear for everyone? So even in the daily regular moderate doses, it gives flatulence. That is why it is uncomfortable for the patients. But in higher doses, it gives you osmotic diarrhea. Clear for everyone? Both of these challenges and side effects. Now, these patients may also be taking multiple medications, so they could have dry mouth, and that can lead to dental caries. For them, fluoride containing toothpaste should also be advised. If the age of the patient is under adolescence, what strength, and over adolescence, what strength? Can anyone give me a review from the TGA fluoride table? Age below 13, what strength, and age above 13? 13 and above, what strength? Fluoride strength, toothpaste strength. Can anyone? So less than 13, up to 1000, and then more than 13, 5000. Right? Below 13, 1000 or 1500. Above 13, 5000. 550, no. What is the age for 550 ppm in high caries risk? In high caries risk, what is the age for? Yes, absolutely correct, Kinjal. So 550 or 500 is below 6. Then 6 to 12 is 1000 or 1500. And above 13 is 5000. Memorize the fluoride table. Always, it should be by heart to you. Put it on your sticky notes. It should go on the wall in front of your study table. All right. So also advise them for the oral lubricants and saliva substitutes if they have the dry mouth. Now, how will you diagnose the oral pain in them? Right? So, diagnosing the oral and dental pain in such patients is a problem. Number one challenge is the communication difficulty. They cannot communicate that they are having pain, and it can really manifests itself as altered behavior, sleep, or diet patterns. They will not be able to tell you that they're having pain, but they will refuse to eat. They'll get aggressive. They'll start drooling, disturb sleep. They'll start inflicting self injury. That is not a normal representation of pain, is it? Is it a normal representation of pain? Refusal to eat, aggression, drooling, disturbed sleep, self-injury. But in these patients, the pain manifests itself in these altered behavioral changes. So you should be educated about these, that it indicates. So now a patient comes and a history is given and he's showing all these indicators. If you're not educated, you would think, oh, he is having some delirium episode. But if you're educated, you will think about it that yes, dental pain in such patients with cognitive disabilities represent itself as these behavioral changes. Yes or no? Now tell me, this comes from being educated about it. Because otherwise, you would think they're having an episode of delirium, which they have, right? And you may say that, okay, refer them to their psychiatrist or change their antidepressants or antipsychotics, right? You might suggest those if you are not educated that these behaviors can come from oral dental pain. Without education, it becomes a challenge for your patient because you are not expert, you're not educated, you're not trained to understand that these are the signs in such patients of pain. So now you see how you are also becoming a challenge for these patients. Now, this is a practical application or not? That how even dental professionals can be challenged for cognitive patients because of their lack of training and expertise. Give me yes or no if it brings to the highlight that if you're actually going and planning to practice there, and if you're planning to treat such patients, your lack of information and your lack of education can compromise a patient's health. Because there is a communication barrier, they cannot verbalize pain, and your lack of training, you would say, okay, take them to the psychiatrist, take them to their behavioral specialist. You may you may miss out on assessing because it can indicate pain. It is an indicator of pain. Then you will use certain pain assessment tools. You should know the names. One is the Wong Baker Faces pain rating, right? You could give it to them and they will choose an option. And the other one is your Abbey pain scale, which also requires you to observe the person. But sometimes, if you start looking at their facial expressions to observe the pain, that can also go wrong because in these patients, sometimes they can even respond to pain as laughing. They can even respond to pain in a laugh through laughing, and that can also confuse you unless you are educated and aware about that. Okay. Now, how will you plan their oral and dental treatment? So there are the moment they call you that they need an appointment, that is exactly when the planning starts. In these patients, the planning starts as soon as they call you. Okay? So first of all, you will arrange for the same person for that person to see the same clinician in every appointment, preferably. But if sometimes it may not always be possible, especially if it's an emergency appointment. If it's not an emergency, try to keep of your practice only one clinician who sees that patient. So anticipate that it will be a longer consultation and they may require multiple visits for shorter treatments. You will give them appointment time in appropriate timing, taking into consideration that what are their needs. They might want very less waiting time. For such patients, give them minimal waiting time. Now that can depend on your practice, what is your busiest hours, and give them the minimal waiting time. Consulting rooms should also be larger if possible. If they don't want to wait inside the waiting room, if they want to wait in their car outside, allow them to wait outside so they don't get overwhelmed of the people in the waiting area. Ask them if they need any communication aids. Do they need any person to assist with communication? Right? If they have any list of medications, you will ask their complete medical history, behavioral support plan. If the behavioral therapist has given them a behavioral support plan, you will ask for that. And you will ask who is going to accompany them, the parent or the support worker or their primary caregiver. Who's the primary caregiver, right? Then ask, if they ask on the booking call only, do they require any mobility aids? Do they require any wheelchair? Does your clinic have that environmental need of the wheelchair accessibility? Do they require any hearing aid, right? And you may also ask them, do they require a prior discussion? The family members, do they require a prior meeting with the clinician before the first appointment? Because in the first appointment, you may not be able to do any treatment. So it could be like an introduction appointment. So ask all these things in their booking call, right? So these should be your preferred booking when you're booking them the appointments. So when you see them, you will completely and clearly, first of all, record their cognitive disability diagnosis. All your dental records should clearly highlight what is their patient's diagnosis. That they have the cognitive disability, this is their diagnosis. Their medical diagnosis should be highlighted on the top of their record. So that if you are not also seeing them, somebody else also is seeing them. They are completely aware by looking at their records, the patient's cognitive disability diagnosis should be clearly mentioned on their records, not hidden in between, but highlighted and clearly mentioned. Okay, then you will see who can give the consent. We'll talk about in depth the next class who gives the consent. But remember, in the cognitive disability also, the priority is given to the wishes of the person who is the patient. Will you remember that? Even if the consent is not coming from the patient, even if the legal consent is coming from the primary care provider or their legal guardian, but the wishes of the patient are prioritized if they are aligning with your treatment strategy. So if the exam question asks you that, would you remember this? Whose treatment planning would be prioritized? Whose wishes would be prioritized? In general population, Nivedita, we answer the question. No, I've given you also, when we do the rash technique also, I give you one of the strategies to look in the history, right? What does patient want? Remember, in our internal classes, when we do the rash technique, when we do the edge component, we talk about it, right? What does patient want? That means in the general population, we always prioritize what does patient want? What are the patient's wishes? Agreed or not, everybody who are enrolled and who are taking the rash technique and internal classes. So we are always prioritizing them. So now you would think that in the cognitive disability that may not apply, right? You may think that, but you know what? Legally, even with the cognitive disability patient, the wishes of the patient, the person, are to be considered. Priyanka, I'm saying, if you remember the rash technique discussion, in the edge component, we talk about it, that what does the patient want? Remember, Priyanka, in the rash technique, one of the factors in the history is what does the patient want? Now, you might think that in a cognitive disability patient, Nidhi, I'll explain rash technique fully in the internal class tomorrow, okay? And you can watch the first two classes that you have missed because you've only recently joined, I remember. So watch the missed classes of UF2. I've explained the rash technique in those two also. Okay. So now in cognitive disability patients, you might think, oh, here the patient, what does patient want may not apply, right? But in planning any significant dental treatment in the patients who have cognitive disability, the wishes of the person should be considered. If the patient says, no, I want implants or I don't want implants, you have to respect their wishes, even in the cognitive disability. You should make an effort to understand the wishes and priorities of patient with cognitive disability. As a professional, it is your duty to even try to ask these patients, communicate with them. No matter how challenging it is, you have to involve these patients also. Okay? And then you will liaise with, collaborate with the family members, person's care team, behavioral therapists and specialist need or medical professionals also. and see what works best for them. See, if the patient's wishes are difficult to ascertain, then you use a treatment plan approach which you think is designed for the population groups who have complex needs. Okay, in the next class, I'll be taking you more in depth about and give you an example also of a patient, older patient, who had a cognitive disability, and in case where the patient's wishes cannot be ascertained or cannot be granted, what treatment planning approach is given. Do you want to learn that? What is the guideline then? What is the treatment planning approach as a rational dental framework? There is a term called rational dental framework for the population groups who have complex needs when their wishes cannot be granted. What rational approach should be advised? By an example, we'll do it in the next part of this series. And we'll also talk about who will give consent, and if the wishes cannot be granted, what should be the approach. Then we'll talk about individual disease and its management. That is the simplest part: dental caries, dental erosion, periodontal disease, malocclusions. These are very, very simple parts. Dental anxiety management, sedation advices, and what is your role, basically. Right? So this would be the second part of this series, where we'll talk about individual disease, anxiety and sedation, and consent. Tomorrow, when we are discussing before consent, the next week, we'll talk about how would you plan the treatment when the patient's needs cannot be ascertained. Then what is a rational dental framework? Okay? In complex needs patients. See, consent is still easy. We have done the article on who gives the consent, the legal consent. Everybody has watched that class or not? Those who are enrolled. If not yet, you will be coming to that class. Those who are carrying forward from the previous batches, they would have watched that class. But those who are new, you will still come to that class. Who would give consent in the medically compromised patients? That includes the cognitive disabilities as well. Okay? So there is sequencing also. Jasmine, legal guardian and next of kin and everything. So I've done that entire Australian Dental Journal article, next of kin and legal guardian and everything. There's a sequence. Must remember that sequence through that article. Understood? Everybody? So a lot of learning. All the challenges and risk factors and oral hygiene advices and strategies. Everything understood so far? Diagnosing oral and dental pain. What are the challenges? What are the behavioral indicators? That's the kind of words that I'm looking for. Was it awesome or not? A lot of learning and a lot of new things that you have never ever read anywhere in any books, in any Australian article so far. And this is fresh from eTG, latest topics. And this is already a high yield question topic in ADC from the past 1 year. These are direct questions already getting asked, and the new questions also that will get asked. You are 100% confidently prepared. Once I complete this, I will give you an assignment on Facebook group if you're not enrolled, and on the WhatsApp group if you're enrolled. I will give you this classes, 4 or 5 classes, and these hot notes, read them. And I will give you the November public mock on this cognitive disability entirely. So I'm giving you the syllabus for November public mock already, okay? That is how we roll in November, and that is how you get an assignment for the first time from Winspur. This is your first time assignment, right? Unpredictable, something extra, but let's roll with it. All right, thank you so much, guys. So next week we'll talk about the rational dental framework, consent taking, talking about the diseases and the management, anxiety management, sedation management. And yeah, that's how we will prepare about the entire dental management. One or two more are left. I think we'll cover them as well. Obstructive sleep apnea also I'll try to cover, and then I'll see what more is new. Okay, but I think one or two more topics, and I'll take your short mocks on them. So you'll get assignments on them, and you'll get extra mocks on them. Okay? All right. Thank you so much, guys. Have a fabulous week ahead. And I wish you a great weekend. For those who are enrolled, I'll see you tomorrow. We'll have our internal UF2 class. We'll do the next 4 pages. We'll talk about the rash technique for those who joined new. And yesterday you joined the 3P session. So I hope that also gave you clarity on how the course is progressing, especially the ones who are just joining. So know that we will have bi-weekly 3P sessions to keep you abreast with the program. So even if you're joining late, you could still join for the March program, and you will be updated and initiated and oriented about the program. So you will not miss out any single thing. We'll continue to take care of you, even if you're joining in the second week or the third week. We continue to take the 3P sessions. Yeah, the 3P has been recorded, Jasmine. I guess it was uploaded on the app. If not, I'll just check it. It should be uploaded. Okay? Thank you very much and see you guys. Bye-bye. Have a great weekend. Thank you so much. Bye-bye.